You know the feeling. I mean, we've all been there. You're standing at the foot of the bed in the intensive care unit.
Oh, yeah. The absolute worst feeling.
Right. The ventilator is alarming. The monitor shows a heart rate climbing past like 130. And the patient, a 35-year-old who was completely healthy 3 days ago, is rapidly slipping into this deep, unarousable coma.
And you're just running the standard playbook.
Exactly. You run the playbook, you order a stat head CT, it comes back completely clean, no bleed, no mass, nothing. You pan culture them, you've got broad spectrum antibiotics hanging, but their inflammatory markers don't scream sepsis at all.
Not even a little bit.
And then you check their liver enzymes, and they are immaculate. I mean, the AST, ALT, bilirubin, the INR, all of it is just perfectly normal.
It is the absolute definition of diagnostic muddy waters. I mean, the standard algorithms, the ones drilled into us during residency, they completely fail in this specific scenario.
They really do.
Right, because the patient just gets labeled with an overwhelming atypical sepsis-associated encephalopathy. Or maybe, the neurology consult comes by and suggests an unseen non-convulsive status epilepticus.
No, or the psychiatry service gets consulted for a primary catatonic crisis. I see that all the time.
Yes, and while all of these entirely reasonable yet entirely wrong avenues are being chased, the actual culprit is quietly, invisibly accumulating in the patient's bloodstream.
And crossing the blood-brain barrier.
Exactly.
Well, welcome to this deep dive. If you're listening to this, you are likely a fellow critical care physician who has faced this exact nightmare at the bedside. We are professors in critical care hepatology, and today's mission is to custom tailor a masterclass for you on adult non-cirrhotic hyperammonemia.
It's a huge topic.
Massive. We are synthesizing some incredibly dense, newly established clinical guidelines today. We're pulling heavily from the recent ammonia masterclass. Physiology to Management and its Foundational Mechanism First Master Chapter.
Those are fantastic sources, by the way.
Really incredible detail. So we are going to build a comprehensive, step-by-step diagnostic and therapeutic workflow for you. We'll move chronologically from the evolutionary origins of nitrogen waste through the exquisite microscopic architecture of the human liver, and then directly to the catastrophic bedside pathophysiology of a brain under siege.
Yeah, and to truly understand why ammonia is so devastating to a human being in the ICU, we actually first have to look at our evolutionary past.
Wait, really? Like, how far back?
Like all the way back to fish.
Okay, I love this. Let's do it.
So life as we know it began in the ocean, right? In that aquatic environment, our earliest ancestors faced absolutely zero water scarcity. They were ammonotelic organisms.
Ammonotelic, meaning they just excrete ammonia directly.
Exactly. Because ammonia, NH3, is this highly toxic, uncharged, highly diffusible gas, these aquatic ancestors could afford to just let it wash away. They used specialized rhesus, or RH, glycoproteins in their gills, to passively diffuse ammonia directly into the endless ocean.
Oh, wow. So they just dump it.
Just dump it. It is a luxurious, brilliant, and extremely low-energy strategy for nitrogen disposal. The ocean literally did all the dilution work for them.
But we obviously didn't have that luxury once we crawled out of the sea. I mean, the moment biology transitioned to dry land, water became the single most precious commodity on the planet.
Oh, 100%.
We couldn't just flush caustic, highly alkaline ammonia out of our systems because, well, diluting it to safe levels would require massive, physiologically impossible volumes of water.
Right, we would literally dehydrate to death just trying to pee.
Which is a terrible way to go.
It really is. So terrestrial mammals were forced by evolutionary pressure to become ureotelic. We had to invent this metabolically exhausting engine, the urea cycle, to capture that toxic ammonia gas and compress it into a highly soluble, osmotically favorable, and essentially harmless powder called urea.
And we spend a phenomenal amount of cellular energy to do this, don't we?
It's crazy. We burn 3 ATP equivalents for every single molecule of urea we create.
It's just to make one molecule.
Just one. And we do it purely so we can concentrate our nitrogen waste in the bladder without destroying our own mucosal tissues.
And the sheer scale of the nitrogen load we deal with is staggering. I mean, for an average adult, we are talking about a daily turnover of 300 to 400 grams of protein.
That's a lot of protein turnover.
It's massive. Every single time a muscle fiber is broken down or every time an enzyme is degraded or rebuilt, amino acids are dismantled and nitrogen is stripped away. And the gastrointestinal tract alone acts as a massive continuous ammonia factory.
Oh yeah, the gut is a huge player here.
Right. You have mucosal enterocytes using the enzyme glutaminase to extract energy from circulating glutamine, generating ammonia as a byproduct. And then you have the gut microbiome.
The rainforest of bacteria.
Yeah, this vast, diverse rainforest of enteric bacteria utilizing urease to aggressively ferment urea and dietary amino acids. Between the two, the gut is dumping roughly 4 grams of raw ammonia nitrogen straight into the portal vein every single day.
And that portal vein is carrying a river of absolute neurotoxin directly to the liver's front door. I mean, if that portal blood bypassed the liver and hit the systemic circulation unchecked, the human brain would succumb to lethal cerebral edema in a matter of hours.
Hours? That's terrifying.
It really is. But the liver doesn't just passively filter this blood. It protects the systemic circulation using a dual-layered, highly zoned defense architecture. We call it hepatic lobule zonation.
Okay, hepatic lobule zonation. I always think of this like a major city's waste management infrastructure. So you have the blood flowing in from the portal triad, and the first thing it hits are the periportal hepatocytes. This is zone 1.
Exactly. Zone 1 is the central treatment plant. It is an incredibly high-capacity system, but it operates with a relatively low affinity for ammonia.
So it takes in a lot, but maybe misses the fine details.
Yeah, precisely. The periportal hepatocytes are packed with mitochondria, and they house the entire, complete urea cycle. Because the ammonia concentration is highest right there, the urea cycle enzymes engage rapidly. They grab the vast bulk of the incoming toxin, fuse it with carbon dioxide, and churn out urea. It handles about 95% of the portal nitrogen load.
That's incredibly efficient, but biological systems are rarely perfectly efficient. A high-capacity system is naturally going to let a few things slip through the cracks. The urea cycle operates fast, but its low affinity means it can't capture every single molecule.
And that's where Zone 3 comes in. About 5% of that portal ammonia drifts downstream, escaping the Zone 1 gauntlet. It moves toward the central vein, threatening to spill into the systemic circulation.
So what's waiting for it?
Waiting right there, in the perivinous zone, Zone 3, is the neighborhood interceptor system. This is a highly concentrated, localized ring of hepatocytes that actually do not possess the urea cycle.
Wait, no urea cycle in zone 3?
Nope. Instead, they are armed with massive concentrations of an enzyme called glutamine synthetase.
Ah, okay. So zone 3 acts as the polishing filter.
A completely ruthless, high-affinity, low-capacity polishing filter. Glutamine synthetase mercilessly scavenges that escaping fugitive ammonia. It binds it to a glutamate molecule, locking it down to form glutamine.
And glutamine is completely safe.
Totally safe. It has no osmotic toxicity in the blood, no pH effects, and it travels freely as a non-toxic transport vessel. The Zone 3 hepatocytes effectively ensure that the blood exiting the central vein and entering the inferior vena cava is entirely free of unbound ammonia.
Okay, wait, hold on. I'm stuck on a paradox here.
Let's hear it.
If the liver is engineered with this exquisite dual-layered fail-safe architecture to eradicate every last trace of ammonia from the blood, why does the human kidney deliberately generate it?
The renal ammonia paradox.
Yeah. It feels completely counterintuitive that one organ is spending massive amounts of ATP to destroy ammonia, while another organ is actively manufacturing it.
It really is one of the most fascinating trade-offs in human physiology. The kidney is an active ammonia factory, yes, but it performs this dangerous chemistry in the absolute service of acid-base survival.
Right, because of metabolic acidosis.
Exactly. During normal daily metabolism, and especially during critical illness in the ICU, the body generates massive amounts of organic acids. To survive, the kidney must constantly excrete these hydrogen ions. So when a patient enters a state of metabolic acidosis, the renal proximal tubule drastically upregulates the extraction of all that circulating glutamine we just mentioned from the Zone 3 hepatocytes.
Oh, I see. And the skeletal muscle is involved here too, right? The muscle acts like a vast, silent sponge, taking ambient ammonia, utilizing its own glutamine synthetase, and shipping glutamine into the bloodstream. It's the glutamine shuttle.
The glutamine shuttle is the highway, and the kidney acts as the primary destination during acidosis. The proximal tubule pulls that glutamine in, and using its own enzyme, glutamase, it violently strips the ammonia off.
Just rips it right back off.
Rips it off. This NH3 diffuses into the urinary lumen. Once in the urine, it binds a hydrogen ion to become the charged ammonium ion NH4 plus sevane. Because it is now charged, it cannot cross back across the tubular membrane.
So the trap.
It is trapped in the urine and flushed away, physically dragging acid out of the body.
Wow. And the physiological elegance there is that the residual carbon skeleton of the glutamine gets metabolized by the kidney into glucose. And that specific metabolic process inherently yields a brand new bicarbonate ion, which goes directly back into the systemic circulation to buffer the blood.
Exactly. Ammonia generation is literally the price we pay to not die of
It's a
acidosis.
brilliant survival mechanism, but it becomes a huge double-edged sword for us as critical care physicians
Yeah.
because acid-base balance dictates the physical behavior of ammonia.
It does. Acidosis traps ammonia in its ionized charged state NH4 plus A. It is water-soluble and largely stays in the blood or urine. But alkalosis drastically shifts that equilibrium.
And we see respiratory alkalosis constantly in the ICU.
Con
Patients are hyperventilating from pain, anxiety, early sepsis, or, even just from aggressive mechanical ventilation settings.
And when the blood pH becomes alkaline, the chemistry forces that safe, charged NH4 plus to give up its proton. It reverts back into the uncharged, highly volatile NH3 gas,
Even dangerous for
the very dangerous form.
hmm
Because NH3 is a small, uncharged lipophilic molecule, it diffuses effortlessly across the lipid bilayers of the blood-brain barrier. The liver's defenses are suddenly irrelevant because the toxin is slipping straight into the central nervous system.
Okay, let me synthesize this before we dive into the microscopic biochemistry, because this is complex.
Please do.
So we are dealing with a fundamental evolutionary compromise. We burn energy to turn toxic ammonia into safe urea so we can survive outside the ocean. Our liver uses a two-part safety net, the Zone 1 bulk disposal and the Zone 3 glutamine scavenger system to keep the blood clean. And our muscles soak up excess nitrogen into glutamine, and our kidneys tear that glutamine apart to make ammonia just to excrete acid and make bicarb. But the moment the patient's blood turns alkaline, all that carefully managed ammonia turns back into a gas and heads straight for the brain.
That is exactly it, which means we need to understand the exact mechanics of the machine that is supposed to prevent this. Because when you were standing over that mysterious coma in the ICU, the specific broken gear in the urea cycle dictates your entire management strategy.
You really have to be able to visualize the enzymes.
You do.
So let's demystify the urea cycle. We've established it is an energy-draining 6-enzyme engine. It is split across two distinct compartments inside the Zone 1 hepatocyte, the mitochondria and the cytosol.
Think of it as a biological airlock. The free ammonia in the hepatocyte is highly toxic, and it's trying to diffuse back into the blood. So the cell forces it deep into the mitochondria for initial capture and stabilization, and then shuttles the intermediate molecule out into the cytosol for the final processing stages.
The airlock, I like that. The mitochondrial phase is where the life or death magic happens, and it starts with an enzyme that doesn't actually touch the ammonia itself, right?
Yeah, step 0 is an enzyme called NAG-EGS, N-acetyl-glutamate synthase. It synthesizes a tiny molecule called NAG. Now, NAG is not an intermediate in the cycle. It is the absolute obligate allosteric activator.
So without NAG,
Without NAG, the entire urea cycle is completely dead. It is the master permission slip for nitrogen disposal.
and that permission slip is handed to the merciless gatekeeper of the cycle, CPS1, or carbamoyl phosphate synthetase 1.
CPS1 is the heavy lifter of the mitochondrial phase. It takes that highly toxic free NH3, grabs a bicarbonate molecule, and forcibly merges them into carbamoyl phosphate. And it burns 2 entire ATP molecules just to execute this single fusion.
So expensive.
So expensive. But CPS1 is a locked door. It cannot physically perform this action unless NAG is bound to it, changing its three-dimensional conformation.
Got it. So NAG unlocks CPS1, which then makes carbamoyl phosphate. What's next?
Once CPS1 turns out carbamoyl phosphate, the next enzyme, OTC ornithine transcarbamylase, takes over.
And OTC takes that newly minted carbamoyl phosphate and fuses it with an amino acid called ornithine to create citrulline.
Citrulline is the crucial handoff molecule. It is the specific intermediate designed to survive the journey out of the mitochondrial matrix, across the membranes, and out into the cytosol.
So citrulline exits the airlock. Now we are in the cytosolic phase. The cycle has to finish the job of creating urea.
Exactly. The cytosolic phase relies on 3 sequential enzymes, ASS1, ASL, and ARG1. First, ASS1 takes the citrulline and fuses it with aspartate. This step burns another ATP equivalent. Like we said, the cycle is ravenous for energy.
It just eats ATP.
It does. Then, ASL takes that massive fused molecule and splits it. It jettisons a carbon skeleton called fumarate.
Oh, and fumarate brilliantly cycles right back into the TCA cycle, the Krebs cycle, to help generate the cellular energy the urea cycle is currently devouring.
And metabolic integration is just beautiful.
It really is.
Finally, the last enzyme, ARG1 arginase 1, steps in. It hydrolyzes the remaining molecule, cleaving off the final product, urea. The urea diffuses into the blood to be cleared by the kidneys, and the leftover molecule is simply ornithine.
Which gets shipped right back into the mitochondria to meet the next carbamoyl phosphate, and the wheel keeps turning.
Exactly. That is the normal, healthy physiology.
All right, but you are a critical care physician. You need to know how to read the wreckage when this machine explodes. The biochemical signatures of failure are left in the blood in urine.
And this is where we transition from basic science to high-level clinical diagnostics. You're looking at two primary biomarkers to pinpoint the broken gear: the citrulline level in the plasma amino acid panel and the uric acid level in the urine.
Okay, so going back to the airlock concept, citrulline is the handoff molecule from the mitochondria. If the mitochondrial enzymes fail, citrulline is never synthesized.
Right. So if you draw plasma amino acids on your comatose patient and the citrulline comes back profoundly low, you know immediately that the break is proximal. The mitochondria have failed.
So a low citrulline points specifically to NAGS, CPS1, or OTC, but how do you differentiate between those three?
You look at the uric acid. If the plasma citrulline is low and the uric acid is normal or low, you are looking at an AGS or CPS1 deficiency.
Because the gatekeeper's never opened.
Exactly. The cycle never started. These are the most rapidly lethal defects because there's absolutely zero alternate pathway for the ammonia.
But what if the citrulline is low and the uric acid is massively high? What does that signature mean?
That is the absolute hallmark of an OTC deficiency, which is actually the most common urea cycle disorder.
Okay, why the high uric acid?
The mechanism there is brilliant metabolic detective work. If OTC is broken, the gatekeeper CPS1 is actually still working perfectly. It is violently merging ammonia and bicarbonate into carbamoyl phosphate, but OTC can't use it. So the carbamoyl phosphate backs up, fills the mitochondria, and eventually leaks out into the cytosol.
And once it's in the cytosol, it crashes into a completely different metabolic pathway.
Yes, it forcefully shunts into the pyrimidine synthesis pathway, which is responsible for building DNA and RNA precursors. The sheer volume of overflowing carbamoyl phosphate overwhelms that pathway, and the resulting toxic byproduct is massive amounts of uric acid, which spills into the urine.
Wow, it's literally an overflow valve.
Exactly.
And just to complete the diagnostic map, what if the plasma citrulline is massively high? We're talking levels over 1,000 micromoles per liter.
That tells you the mitochondria are working perfectly. They are churning out citrulline and sending it out the airlock. But the cytosolic enzymes are broken. Specifically, it points to an ASS1 deficiency, clinically known as citrullinemia type 1. The citrulline hits a brick wall in the cytosol and accumulates to massive levels in the blood.
You know, I can hear the intensive care physicians listening to this thinking, okay, this is fascinating pediatrics, but these are congenital, autosomal, recessive, or X-linked genetic defects. If a patient is born without CPS1 or OTC, they present in a hyperammonemic coma in the neonatal ICU at 4 days old. Why am I, an adult intensivist, supposed to care about this in a 35-year-old?
And that is one of the most dangerous medical myths out there, that urea cycle disorders only exist in pediatrics.
It's just not true.
It's not. The reality is that genetic mutations are rarely binary. Many patients have a partial or hypomorphic mutation. Their enzymes aren't completely missing, they're just structurally inefficient. Their urea cycle operates at perhaps 15 or 20% of normal capacity.
So, enough to handle the peacetime nitrogen load of childhood and adolescence, but with absolutely zero metabolic reserve for wartime.
Precisely. They survive into adulthood with subtle, often ignored clues. Maybe they have a lifelong subconscious aversion to high-protein foods. Maybe they had unexplained episodes of cyclical vomiting or lethargy after a severe flu.
But they reach 35 years old, and suddenly a massive catabolic stressor hits them.
Right. A traumatic injury, a massive dose of corticosteroids, or the physiological strain of giving birth. The metabolic load suddenly demands 100% capacity from a machine that maxes out at 20%. The urea cycle is pushed past its breaking point, fails catastrophically, and the adult presents to your ICU with acute, life-threatening hyperammonemia.
And when that ammonia escapes the liver, the organ that pays the ultimate devastating price is the brain. Let's move into the pathophysiology of the central nervous system, because why is the brain so uniquely, exquisitely vulnerable to this specific toxin?
Because the human brain completely lacks a urea cycle. It just doesn't possess the heavy mitochondrial machinery to detoxify nitrogen.
None at all.
None. So when the hepatic barricade fails and that uncharged NH3 gas glides effortlessly across the lipid bilayers of the blood-brain barrier, the brain is essentially caught without a shield.
But the brain isn't entirely defenseless, is it? I mean, we know it has a local response.
It relies on a single, desperate, and ultimately fatal line of defense: the astrocytes. Astrocytes are the crucial supporting glial cells of the brain, responsible for maintaining the environment for neurons. And crucially, astrocytes express high concentrations of glutamine synthetase, much like the zone 3 hepatocytes.
So when the ammonia gas floods the cerebral cortex, the astrocytes furiously attempt to scavenge it, combining it with local glutamate neurotransmitters to form glutamine.
Right, and for decades, standard medical teaching told us that this is the whole story. We were taught that the synthesized glutamine was simply an osmotically active byproduct. It piled up in the astrocytes, drew massive amounts of water in through osmosis, and caused the brain to swell.
Which makes sense. Osmosis is a powerful force.
The osmotic swelling is absolutely real, and it creates a severe cytotoxic edema. But the modern understanding of hyperammonemia reveals a deeper, much more insidious mechanism at play. This is what we call the Trojan horse hypothesis.
A Trojan horse hypothesis.
Yes, and it explains why the cellular destruction is so rapid and so permanent.
Walk us through the exact molecular interaction inside that swelling astrocyte. How does glutamine act as a Trojan horse?
Well, so the astrocyte synthesizes the glutamine in its cytosol as a desperate attempt to neutralize the ammonia, but glutamine is actively transported in massive quantities into the astrocytic mitochondria.
Okay, so it goes inside the mitochondria.
Right, and once it gets inside that vital organelle, a resident enzyme called phosphate activating glutaminase, or PAG, encounters it.
Wait, glutaminase? The exact same enzyme the kidney uses to strip ammonia off glutamine.
The exact same enzyme. The astrocyte inadvertently ships the toxin directly into its own powerhouse, and the PAG enzyme cleaves the glutamine, detonating a localized ammonia bomb directly inside the mitochondrial matrix.
That is horrifying. I mean, the astrocyte's defense mechanism literally ensures its own destruction. What does that intramitochondrial ammonia bomb actually do to the cell?
It completely cripples the electron transport chain. The high concentration of localized ammonia generates a devastating storm of reactive oxygen species and reactive nitrogen species. This intense oxidative terror attacks the mitochondrial membranes and forces open a structure called the mitochondrial permeability transition pore, or the MPT pore.
And once the MPT pore is blown open, the game is over for that cell, right?
It's over. You get a complete collapse of the mitochondrial membrane potential. ATP production halts entirely. Terminal energy failure sets in.
So it's a dual tragedy. You have massive cytosolic glutamine drawing water in, causing the astrocyte to violently balloon outwards in osmotic swelling, and simultaneously you have the Trojan horse detonation causing irreversible mitochondrial death.
Exactly.
And while the astrocytes are dying, we are also actively destroying the brain's fundamental electrical wiring, because to manufacture all that glutamine, the astrocyte is frantically consuming glutamate.
Which is the brain's primary excitatory neurotransmitter.
Right.
So the neurotransmitter depletion is profound, but the extracellular ammonia is also causing direct electrical chaos. High levels of NH3 directly inhibit the clearance of potassium via the NKCC1 transporter on the neuronal membranes.
So potassium builds up extracellularly?
Yes, which short-circuits neuronal action potentials. The neurons lose their resting membrane potential. They become violently hyperexcitable.
So look at the clinical picture you are facing at the bedside. You have a brain that is osmotically ballooning. Its energy source is utterly destroyed by oxidative stress. Its excitatory neurotransmitters are depleted, and its electrical resting state is short-circuiting.
It's a total catastrophe. The patient becomes agitated, deeply confused, and then rapidly spirals into relentless seizures, decerebrate posturing, and ultimately fatal brainstem herniation.
Because the swelling has nowhere to go within the rigid, bony container of the skull.
Exactly, which is exactly why we must draw a stark, critical contrast between an acute non-cirrhotic presentation and a chronic cirrhotic presentation. This is where classical hepatology teaching often misleads the critical care physician.
Yes, because every intensivist has seen a chronic cirrhotic patient with end-stage liver disease who comes into the ER with a systemic ammonia level of, say, 150 micromoles per liter, and they are awake.
Right, they might be a little lethargic, maybe they have a subtle asterixis or flap in their hands, but they are protecting their airway.
However, if you have an acute non-cirrhotic patient with an ammonia of 150, they are actively seizing and herniating their brainstem. It's the exact same chemical, the exact same concentration. Why is the clinical manifestation so wildly different?
It comes down entirely to the velocity of the elevation. In a cirrhotic patient, the liver fails gradually over years. The brain has months to adapt to the slowly rising ammonia tide. The astrocytes actively downregulate their glutamine synthetase to limit the Trojan horse effect.
Oh, that's smart.
And more importantly, they deploy compensatory osmolyte shifts. They actively pump out other intracellular osmolytes like myoinositol to balance the osmotic pressure. The brain literally shrinks its other cellular contents to make physical room for the accumulating glutamine.
So it's a slow motion adaptation. But the previously healthy 35-year-old adult whose partial urea cycle defect was just unmasked, they have absolutely zero time to adapt.
None. The velocity of the ammonia spike is staggering. Because the rise is acute, there is no myoinositol shift. The water floods the astrocytes unimpeded, the Trojan horse detonates before the cell can downregulate its enzymes, and the resulting cytotoxic edema is massive and rapidly lethal.
Let me bring up a major clinical trap here. I see these undifferentiated patients in the emergency department, and hours before they slip into the coma, they are frequently hyperventilating, they are breathing 35 times a minute, and their blood gas shows a profound respiratory alkalosis.
It's so common.
And the immediate cognitive bias is, they're panicked because they are confused, or they have early sepsis and are compensating for an unseen metabolic acidosis.
And that cognitive bias kills patients. It is not panic, and it is rarely early sepsis. The uncharged ammonia gas, crossing the blood-brain barrier, is directly stimulating the brainstem respiratory centers. The body senses the neurotoxin and desperately attempts to clear it, but the resulting hyperventilation paradoxically accelerates the crisis.
Because of the acid-base chemistry we discussed earlier.
Exactly. The extreme hyperventilation blows off massive amounts of CO2, creating a profound systemic alkalosis. That alkaline blood pH forces whatever safe, charged NH4+ is left in the circulation to drop its proton and shift into the uncharged NH3 gas phase.
And this gas diffuses even faster across the blood-brain barrier.
Right. The brain's attempt to save itself is literally accelerating its own poisoning.
Wow. So, if I'm tracking this right, the brain has no urea cycle. It relies on astrocytes to turn ammonia into glutamine. But this glutamine acts as a Trojan horse, entering the mitochondria, getting cleaved by PAG and destroying the cell from the inside out with oxidative stress, while simultaneously causing massive osmotic swelling and electrical failure.
Spot on.
And a chronic cirrhotic brain can shift osmolytes over months to survive, but an acute spike in a healthy adult is a high-velocity death sentence. And we must never dismiss primary hyperventilation and respiratory alkalosis as mere panic. It is the brainstem crying for help while simultaneously driving the toxin deeper into the tissue.
Beautifully summarized. Which brings us to the most practical part of our deep dive, the bedside detective. We need a rigorous diagnostic algorithm to catch these clinical chameleons before the brain herniates. When the X-ray machine of standard diagnostics is broken, how do we find the fracture?
Let's start with the first-pass algorithm for identifying non-cirrhotic causes in the ICU. You are on shift, and the lab calls with a critical value, an ammonia of 180. What is your literal step one?
Step one is looking at the patient and asking, is this patient actually encephalopathic?
Meaning, are they confused or comatose?
Right. If the lab calls with an ammonia of 180 and your patient is sitting up in bed, eating a turkey sandwich and doing a crossword puzzle, you almost certainly have a pre-analytical lab error.
Because drawing an accurate ammonia level is notoriously tricky. It is one of the most artifact-prone labs we send.
It requires extreme precision. You must ensure proper sample collection. It needs to be a free-flowing venous draw or drawn from an arterial line, and you must use absolutely no tourniquet.
Wait, why does a tourniquet ruin the lab?
Because a tight tourniquet causes localized muscle ischemia in the arm.
Ah, right.
The ischemic muscle immediately starts breaking down ATP and generating its own local ammonia, which floods the sample tube and gives you a falsely terrifying reading. Furthermore, the tube must be placed on IC the second the blood is drawn, and it must be run through the lab analyzer within 15 minutes.
And if it's not?
If that tube sits in a warm pneumatic tube system or on a counter at room temperature, the red blood cells within the sample will metabolize their own amino acids, generating massive amounts of in vitro ammonia.
Okay, but let's say the draw is flawless. Arterial line directly on ice, run in 5 minutes, and the patient is profoundly encephalopathic.
Then you initiate the algorithm. You check your blood gas, specifically looking for that primary respiratory alkalosis. You check your comprehensive metabolic panel, your INR, your albumin, and you order a STAT right upper quadrant ultrasound with Doppler.
You must definitively rule out cirrhosis and portosystemic shunts.
Right. If they are known cirrhotic, your pathway is clear. You hunt for the precipitants of hepatic encephalopathy, like a variceal bleed, a spontaneous bacterial peritonitis, or severe constipation.
But if the liver architecture is pristine, the enzymes are flat, and the ultrasound is perfectly normal.
Then you are officially in the non-cirrhotic nightmare scenario. You need to move to unmasking hidden urea cycle disorders. We need to look for the triggers that broke the hypomorphic enzymes.
What specific histories are we hunting for?
We are hunting for anything that induces sudden massive catabolism or an overwhelming endogenous protein load. You are looking for the young woman who is 3 to 7 days postpartum. You are looking for the severe asthmatic or autoimmune patient who was just hit with a pulse dose of high-dose corticosteroids.
Or dietary stuff, right?
Yes. You're looking for the patient who rapidly lost weight by starting a strict ketogenic or carnivore diet, or the bodybuilder consuming massive quantities of whey protein shakes. Or simply a patient fighting a severe hypermetabolic viral or bacterial infection.
And the diagnostic urgency at this specific moment is paramount. You have to draw the advanced biochemical labs, the plasma amino acids for citrulline, and the urine organic acids for orotic acid before you start the heavy life-saving treatments, right?
Yeah. Yes, it is the most common mistake intensivists make. If you start high-dose medical scavengers or initiate continuous dialysis before you draw those specific labs, you will instantly alter the patient's biochemical signature.
You essentially erase the crime scene.
Exactly. You must draw the blood and urine immediately so you can capture the low citrulline or the high orotic acid. The metabolic geneticists need that fingerprint to confirm the specific enzyme defect days later when the patient is recovering.
Now, what if it's not a genetic defect at all? What if we are looking at medication-induced hyperammonemia?
This is critical to catch early because it is instantly biochemically reversible. And the absolute biggest offender we see causing mysterious comas in the ICU is valproate or valproic acid, commonly used for epilepsy or bipolar disorder.
Let's break down how a standard seizure medication entirely dismantles the liver's nitrogen disposal system.
It is a fascinating cascading molecular blockade. Valproate metabolism actively binds to and consumes coenzyme A within the hepatocyte. By aggressively sequestering CoA, valproate severely depletes the body's intracellular stores of L-carnitine.
The carnitine shuttle. We learned about that in biochemistry. That's the mechanism the cell uses to drag long-chain fatty acids into the mitochondria so they can undergo beta oxidation for energy.
Exactly. Without carnitine, beta oxidation completely halts. The mitochondria are suddenly starved of their primary energy byproduct, acetyl-CoA.
Oh, I see where this is going.
Connect this back to our urea cycle breakdown. Do you remember the master permission slip required to start the cycle?
N-acetylglutamate, NAG, synthesized by the NAGS enzyme.
Yes. The structural precursors required by NAGS to build that NAG molecule are glutamate and acetyl-CoA. If valproate depletes the carnitine, which halts beta oxidation, which starves the mitochondria of acetyl-CoA, the body cannot manufacture NAG.
And without NAG, a merciless gatekeeper, CPS1, loses its allosteric activator and slams shut.
Exactly. The entire urea cycle dies, purely from a drug side effect.
That is an incredible lethal domino effect. And often, these neurology patients are on polypharmacy. What about topiramate?
Topiramate is synergistically toxic in this exact scenario. Topiramate acts as a carbonic anhydrase inhibitor, which directly reduces systemic bicarbonate levels. Since CPS1 requires both free ammonia and bicarbonate to synthesize carbamoyl phosphate, topiramate essentially starves the broken engine of its second fuel source.
So the intervention is rapid. Stop the antiepileptics immediately and administer high-dose IV L-carnitine to replenish the shuttle, restart beta oxidation, generate acetyl-CoA, rebuild the NAG, and force the CPS1 gate back open.
It works like magic if you catch it.
Now, let's look at another pathway. This one completely blew my mind when I read the source material. The urinary Trojan horse.
Oh, this represents one of the most insidious, easily missed ICU diagnostic pitfalls. You have a patient with a perfectly healthy liver, perfectly normal genetics, and they are not taking valproate. Yet they are lying in your ICU in a deep hyperammonemic coma.
Where is the massive nitrogen load coming from if the liver works?
The bladder.
The bladder.
Imagine an elderly patient, perhaps with benign prostatic hyperplasia or a neurogenic spinal cord injury. They have an obstructed, massively distended bladder. They develop a urinary tract infection, but not just any standard E. coli UTI. They become colonized with a specific urease-producing bacterium. We're talking about organisms like Corynebacterium regelia, Corynebacterium ureolyticum, or Proteus mirabilis.
So these bugs express massive industrial amounts of the urease enzyme.
Right. And they sit in that stagnant, obstructed pool of urine. They take the harmless, highly concentrated urea that the healthy kidneys just spent vast amounts of energy to filter out, and they violently cleave it right back into raw ammonia gas and carbon dioxide.
So the patient's bladder structurally transforms into an enclosed, highly pressurized ammonia factory.
Yes. And here is the anatomical marvel of this pathology. Because of all that urease activity, the urine becomes highly alkaline. The pH shoots up to 8.5 or 9.0.
Which means it exists as a gas.
Exactly.
All right.
Because it's alkaline, the ammonia exists as the uncharged NH3 gas.
Right.
And because the bladder is obstructed and under high hydrostatic pressure, that NH3 gas is forced to back diffuse directly across the bladder mucosa and into the vesical venous plexus.
Wow. And the vesical venous plexus drains directly into the iliac veins and straight into the inferior vena cava. It goes straight to the right heart.
It completely anatomically bypasses the hepatic portal system.
The gas never goes to the liver.
Never. The liver is healthy, capable, and waiting, but it never gets a chance to detoxify the ammonia because the anatomical routing circumvents it entirely.
Which means if you misdiagnose this as standard hepatic encephalopathy and you give this patient standard cirrhotic therapies like oral lactulose or rifaximin to clear the gut, it is entirely, utterly useless.
Completely useless. The factory producing the toxin is in the bladder, not the gastrointestinal tract. You are treating the wrong organ.
So, to review our bedside diagnostic pathways before we look at real patients. Ensure a flawless blood draw without a tourniquet. Rule out cirrhosis immediately. Look for triggers of adult-onset genetic defects like postpartum stress or keto diets, and draw the critical amino acid labs before treating.
Right.
Identify valproate toxicity, which starves the urea cycle of carnitine and NAG. And always look for the obstructed bladder acting as an anatomical bypass factory. Let's put this pathophysiology into actual high-stakes ICU scenarios. I want to dissect real-world clinical case studies to see how these errors are made.
Real cases really highlight the cognitive biases we all fall victim to. Let's look at case 1, the postpartum urea cycle unmasking. We have a 30-year-old, previously perfectly healthy female. It is day 4 postpartum after a relatively normal delivery. She acutely becomes combative in her room, starts hallucinating, and becomes floridly psychotic.
The immediate diagnostic error here is anchoring on a primary psychiatric diagnosis. Every obstetrician and intensivist immediately thinks of postpartum depression progressing to postpartum psychosis. It happens constantly. But what is actually happening to her metabolically?
She has a silent partial hypomorphic defect in her OTC gene, located on one of her X chromosomes. Because she is female, her other healthy X chromosome produced enough functional OTC enzyme to handle her daily nitrogen load throughout her entire life. She never knew she was sick.
Right.
But the postpartum period is a metabolic hurricane. Uterine involution, the rapid massive breakdown of the enlarged uterus back to its normal size, combined with the immense metabolic stress and protein demands of initiating lactation, dropped a catastrophic endogenous protein load onto her system.
The peacetime capacity of her partial urea cycle was completely overrun by the wartime demands of the postpartum state.
Exactly. The citrulline production failed. The ammonia spiked dramatically over 24 hours. The uncharged gas crossed her blood-brain barrier. It triggered the brainstem, causing the respiratory alkalosis that drove even more gas into the brain.
And then the glutamine Trojan horse detonated in her astrocytes.
Yes, and the resulting depletion of glutamate and electrical short-circuiting manifested clinically as acute psychosis. If the intensivist consults psychiatry and simply administers Haldol without checking a stat ammonia level and suspecting a hidden UCD, she will progress to seizures, uncal herniation, and death within 48 hours.
That is just terrifying. Let's move to case 2, the valproate topiramate encephalopathy. We have a 35-year-old patient with a history of difficult-to-control epilepsy. They are brought to the ED lethargic, confused, and actively seizing. The initial thought is standard post-ictal state or status epilepticus, but their ammonia comes back at 210 micromoles per liter. The liver enzymes are perfectly flat.
We mapped this specific mechanism earlier. The valproate aggressively bound her coenzyme A, depleting her L-carnitine shuttle, which starved her mitochondria of the acetyl-CoA needed to make NAG.
Right, the domino effect.
Without NAG, CPS1 shut down. Furthermore, the topiramate she was concurrently taking acted as a carbonic anhydrase inhibitor, lowering her systemic bicarbonate, depriving the crippled CPS1 of its required substrate.
The immediate intervention for this specific scenario is critical.
You stop both anti-epileptic drugs instantly. You do not reach for lactulose. You administer immediate high-dose IV L-carnitine.
Because the exogenous carnitine bypasses the valproate blockade.
Exactly. It replenishes the mitochondrial shuttle, restarts beta-oxidation, reboots NAG synthesis, and forces the CPS1 gate open. The urea cycle turns back on, the patient wakes up.
Incredible. Let's look at case 3, the obstructed urinary tract. We have a 76-year-old male with a known history of severe benign prostatic hyperplasia, BPH. He presents from a nursing home deeply comatose. His ammonia is 380. The liver ultrasound is normal, but the vital clue is his urinalysis, which shows a staggering pH of 8.5.
This is the classic urinary Trojan horse. His grossly enlarged prostate caused chronic urinary retention. The stagnant bladder became heavily colonized by Corynebacterium rigeli. The massive urease production cleaved the urinary urea into ammonia gas.
And the high pH kept it in the gas phase.
Right, and the extreme bladder distension created the hydrostatic pressure gradient that forced the gas directly into the vesical venous plexus, bypassing the liver completely.
And the intensivist's intervention here is brilliantly structurally simple.
Immediate Foley catheter decompression. The moment you drain the liter of stagnant urine, you instantly drop the hydrostatic pressure gradient. The back diffusion of gas into the bloodstream halts immediately.
And then you hit the bacteria with targeted antibiotics, like vancomycin for the C. rigeli.
Exactly. The coma can completely resolve within 24 to 48 hours just by physically draining the bladder and stopping the urease factory.
Amazing. Okay, case 4. The post-bariatric catastrophe, clinically referred to as Guillain-Barré syndrome, gastric bypass hyperammonemia. A 45-year-old female, 3 years post-Roux-en-Y gastric bypass surgery. She presents with severe cyclical vomiting, lethargy, and rapidly declining mental status. Why does a stomach surgery lead to a coma?
Bariatric surgery, specifically Roux-en-Y, radically alters the anatomy of nutrient absorption by bypassing the duodenum and proximal jejunum. Over years, this anatomical rerouting causes profound, insidious micronutrient deficiencies. In this syndrome, the patient develops severe deficiencies in zinc and arginine.
And arginine isn't just a random amino acid. It is structurally critical for the urea cycle to function.
Yes, arginine is absolutely required to keep the cytosolic enzymes ASS1 and ASL functioning at optimal capacity. Furthermore, zinc is a crucial cofactor for the OTC enzyme in the mitochondria.
Oh, wow, so the cycle is hit from multiple sides.
The severe chronic malabsorption silently stalled the entire urea cycle. The cycle was operating on fumes. Then she contracted a minor viral illness, perhaps gastroenteritis, which caused a mild catabolic stress. That minor stress was enough to collapse the fragile, nutrient-starved cycle entirely.
So she needs massive IV arginine repletion, aggressive medical scavengers, and intense nutritional rescue to survive.
Exactly.
Let's do one more. Case 5. The lung transplant recipient. A 45-year-old male undergoes a successful double lung transplant. On day 7 post-op, his liver enzymes are fine, but he develops devastating rapid-onset cerebral edema. His systemic ammonia is over 500.
This represents a terrifying emerging infectious syndrome in the transplant world. The donor lungs were silently colonized by ureaplasma or mycoplasma species. These are unique organisms called mollicutes. They completely lack a cell wall, making them resistant to many standard antibiotics.
And crucially, they express urease.
Massive, unrelenting amounts of urease. Because the transplant recipient is on heavy multi-drug immunosuppression to prevent organ rejection, the ureaplasma replicates uncontrollably and disseminates directly from the lung tissue into the systemic bloodstream.
So the bacteria are literally swimming in the blood.
Right, utilizing the systemic urea to produce ammonia directly inside the circulation. It is a fulminant, almost universally fatal hyperammonemia syndrome unless recognized immediately and treated with specific targeted antibiotics like targeted macrolides or fluoroquinolones combined with continuous dialysis.
So what's the fundamental common thread across all these scenarios? Whether it's a hidden genetic defect overwhelmed by postpartum physiology, a drug reaction destroying carnitine, an obstructed bladder acting as a gas factory, nutrient starvation post-gastric bypass, or a systemic ureaplasma infection from a donor lung through. The initial symptoms are identical.
They are.
They universally mimic primary psychiatric crises, status epilepticus, or bizarre culture-negative sepsis. How do we train our clinical intuition to catch this earlier?
We have to fundamentally shift our diagnostic paradigms. We must stop assuming that an altered mental status in a patient with a healthy liver is always a stroke, an infection, or a drug overdose. You must look for the unexplained respiratory alkalosis.
The hyperventilation.
Yes. You must aggressively question the family about recent fasting, sudden weight loss diets, new anti-epileptics, or a lifelong aversion to meat. You have to train yourself to cast a much wider metabolic net when the clinical picture doesn't perfectly align with the standard ICU textbook diagnoses.
Which demands we move to the final, most critical phase of our deep dive. Once you recognize this clinical chameleon, how do you actually kill it? Let's walk through the specific bedside logic for therapeutic
We
interventions.
start with emergency interventions. Number one, stop all protein intake instantly. Whether the patient is receiving total parenteral nutrition, nasogastric tube feeds, or a regular hospital diet tray.
Right, because every single gram of exogenous protein adds substrate to a clearance engine that is already broken. You have to shut off the tap.
Exactly. Number two, start intravenous dextrose 10%. You must halt the body's endogenous muscle catabolism. If the patient is fasting or severely ill, their body perceives starvation. It begins aggressively breaking down its own skeletal muscle for fuel, which generates massive internal amounts of ammonia.
By pushing high concentration D10, you are metabolically signaling the body. You have abundant glucose. Stop dismantling the muscle tissue.
Precisely. Number three, treat the seizures. But as we've learned, you must be incredibly careful here.
Yes, because if the hyperammonemia triggers clinical or subclinical seizures, you use levetiracetam. You never, ever use valproate to break an ammonia-induced seizure.
Never. For all the reasons we just discussed regarding L-carnitine depletion, you will permanently shut down whatever remaining urea cycle function the patient has.
And number 4, implement aggressive ICU-level cerebral edema precautions. Elevate the head of the bed to 30 degrees to promote venous drainage, aggressively prevent hyperthermia, which increases cerebral metabolic demand, and tightly control serum sodium to prevent exacerbating the osmotic shifts.
But once those temporizing measures are in place, we hit the heavy artillery. Let's discuss the decision triggers for medical scavengers versus immediate hemodialysis.
Let's start with the medical scavengers. You initiate intravenous sodium benzoate and sodium phenylacetate empirically if the systemic ammonia is greater than 100 micromoles per liter and the patient exhibits any clinical signs of encephalopathy. How do these scavengers actually work? They seem like magic.
They are brilliant molecular hacks. They operate by entirely bypassing the broken urea cycle. Sodium benzoate chemically binds to the amino acid glycine to form hippuric acid. Sodium phenylacetate binds directly to the circulating glutamine, the very molecule causing the Trojan horse effect, to form phenylacetylglutamine.
And both of these newly formed compounds are highly water-soluble.
Right, and can be excreted directly by the kidneys. The scavengers basically grab the systemic nitrogen and drag it out of the body through a metabolic side door.
But sometimes that metabolic side door isn't wide enough or it doesn't work fast enough. When do we pull the trigger for mechanical immediate dialysis?
You strongly consider immediate dialysis if the ammonia is over 300 to 500 micromoles per liter, especially in an acute, non-cirrhotic patient where the brain has had zero time to adapt.
Or, regardless of the absolute number, you dialyze immediately if there are hard clinical signs of impending brainstem herniation.
Yes. Decerebrate posturing, unilateral pupil dilation, or loss of cranial nerve reflexes.
And there's a major ongoing debate in the critical care community about the specific dialysis modalities, intermittent hemodialysis versus continuous renal replacement therapy. What's the verdict?
In an acute, severe hyperammonemic crisis, high-flow intermittent hemodialysis, or HD, is vastly preferred as the initial intervention. HD provides the fastest, most aggressive, highest velocity reduction of blood ammonia. It clears the toxin from the intravascular space at a highest possible rate.
But, and this is the critical caveat that intensivists miss, it must be followed immediately and strictly by continuous renal replacement therapy, or CRRT.
Yes.
Why the mandatory switch? Why not just do HD once a day?
Because of the massive rebound effect. Ammonia isn't just in the blood. It is heavily sequestered in the body's tissues, the skeletal muscle, and the intracellular water. HD cleans the blood compartment incredibly quickly, but the moment you stop the machine, the massive stores of ammonia in the tissues rapidly equilibrate back down their concentration gradient into the newly cleaned blood.
So the blood level aggressively spikes again within hours.
Exactly. By switching to CRRT, you provide that sustained, continuous 24-hour clearance required to catch the tissue rebound and prevent a secondary catastrophic wave of cerebral edema.
And let's not forget the targeted advanced therapeutics. What is the role of N-carbonyl glutamate, also known as carglumic acid?
If you draw the labs and suspect a proximal defect, an EGS or CPS1 deficiency, where the citrulline is undetectable, carglumic acid is a literal miracle drug. It is a synthetic, structurally modified analog of NAG.
So it bypasses the need to make your own egg.
Right. It crosses into the mitochondria, binds to the inactive CPS1 enzyme, and forcibly activates it. It can reboot a dead urea cycle almost instantly.
So to conceptualize the acute therapy at the bedside, dialysis is frantically bailing water out of a sinking boat with a massive bucket. Scavengers are plugging the holes in the hull with whatever you can find. And pushing 5E dextrose 10% is actively shutting off the rain pouring down from above.
That is a perfect framework for bedside management.
But I want to ask about interpreting the ammonia level itself, because I see doctors fixate on the absolute number. Is that a dangerous cognitive trap?
It is extremely dangerous to treat the lab value and not the patient's brain. If you have an asymptomatic, awake adult, maybe with chronic liver disease, and their ammonia is 90, that does not mean you call the nephrologist for emergency dialysis. It requires investigation. Sure, check how the lab was drawn, look for urinary retention, but you do not panic.
Because the velocity and the trajectory matter vastly more than the absolute peak number.
Precisely. A rapidly rising trajectory from 30 to 180 over just 12 hours, like in our unmasked postpartum OTC female, is a red alert for impending herniation. The brain is drowning before it can shift its osmolytes. But here is the most terrifying disconnect in hyperammonemia management. In severe late-stage encephalopathy, the systemic ammonia level might actually fall.
Wait, the lab value improves while the patient is actively dying?
Yes. If the Trojan horse mechanism has fully progressed and the MPT pores in the astrocytic mitochondria are blown wide open, the brain is undergoing irreversible necrosis.
Oh, wow.
The systemic ammonia might fall as the liver slowly catches up where the scavengers start to work, but the cellular damage in the cortex is permanent. The total duration of the coma prior to initiating dialysis matters vastly more for survival than the peak ammonia level.
So if you wait for the number to come down on its own while the patient is posturing, you will lose the brain.
You will. A falling ammonia in a deep coma does not mean the patient is recovering. It often just means the damage is already done.
And finally, what happens when we pull these patients back from the brink? What is the long-term management for the survivors once they leave the ICU?
It requires incredibly deep longitudinal biochemical management. We partner with metabolic geneticists to perform stable isotope ureagenesis studies. This allows us to map the precise fractional enzyme capacity of their liver.
And patient education must be huge.
Massive. We educate them to strictly avoid high-dose corticosteroids, which induce catabolism. We set up emergency sick day protocols, so if they get a minor flu, they immediately institute high-calorie, low-protein diets to prevent muscle breakdown.
And we absolutely mandate next-generation genetic sequencing to identify the cryptic hypomorphic mutations that set the trap in the first place.
Always.
Well, we have covered an immense, staggering amount of ground today. Let me synthesize our entire journey before we close. We started with the evolutionary physiology of ancient aquatic life, recognizing the massive metabolic price we pay to turn toxic ammonia into safe urea just to survive on dry land. We navigated the microscopic, dual-layered zonation of the liver, understanding how Zone 1 does the heavy lifting while Zone 3 acts as the critical scavenger net. We unpacked the complex 3-ATP engine of the urea cycle and learned how to read citrulline and orotic acid levels to pinpoint the exact broken enzyme.
Which is key for diagnostics.
Exactly. And we brought all of this to the high-stakes bedside of the critical care unit. You now have the mechanistic framework to spot the clinical chameleons of non-cirrhotic hyperammonemia. You understand the insidious molecular cascade of how valproate starves the cycle of carnitine, why an obstructed bladder infected with urese-producing bugs can bypass the liver entirely, and why the astrocytic Trojan horse makes respiratory alkalosis and this gas so devastatingly lethal to the brain.
And the therapy follows the mechanism.
Right. Acute therapy is logical once you see the mechanism. Stop the protein, give D10 to stop catabolism, avoid valproate, use scavengers for side door excretion, and hit them hard with HD followed by CRRT if the brain is threatening to herniate.
I want to leave you with a final reflection to mull over as you walk back onto your ICU wards. Consider the grand biological irony of this disease process.
The irony.
Yeah, the precise, intricate metabolic engine that allowed our early aquatic ancestors to crawl out of the sea, conserve water, and survive on dry land the urea cycle is the exact same vulnerability that fatally traps our patients when it fails.
Wow, that's heavy.
When severe hyperammonemia strikes, our terrestrial biology violently, metabolically, reverts to an aquatic state. We begin producing a toxin meant to be diffused into an endless ocean. But our brain, encased in a rigid, bony skull, cannot diffuse the toxin away. it tragically drowns in its own evolutionary compromise.
Man, that is profound.
It makes you wonder, as we manipulate human physiology with complex surgeries, powerful drugs, and aggressive ICU interventions, what other ancient silent metabolic adaptations are just waiting to fail at the bedside?